Welcome to Future of Caregiving.
So I ended up enrolling in the School of Nursing, and I was the only male in the entire school for about the 4 years that I was in undergraduate program.
Today, I am so excited to be speaking with Dr. Reg Williams. Dr. Reg has an extensive and impressive clinical, research, and educational career. He maintains a practice at the Depression Center, Department of Psychiatry, where he carries a caseload of patients experiencing depression. He was also the principal investigator for several research grants, studying stress, coping, and depression, specifically in members of the military. And additionally, Dr. Reg has received numerous awards for his teaching through the University of Michigan School of Nursing. Hi, I'm your host, Leah Warnke, and this is Future of Caregiving, where we explore the rapidly evolving world of caregiving. From technological advancements to demographic shifts, we'll delve into the challenges and opportunities that lie ahead for those who provide care and those who receive it. To start us off, do you mind giving a snapshot of what you do and how you got there?
Oh my, I've had kind of a sorted sort of venture in terms of my career. Let's see, maybe go back in time as to kind of where things sort of evolved. And it was rather interesting because I was in high school, graduating from high school when the Vietnam War had begun. And so young men were drafted. And if you weren't in college, you were draft age. And so I certainly knew that. And I definitely wanted to go to college. So I did. And then I went to a junior college and sort of a community college in my area that I lived in. And after completing that, I went to University of Utah in Salt Lake City. But that was where I was sort of struggling. Okay, what do I want to be when I grow up? And I floundered like typically so many students do as to what do I want to do? What do I want to focus in on? So what happened is I decided I better get serious here to figure out what it is that I want to do. Now, keep in mind, in the backdrop is the fact that as soon as you finish college, you were going into the draft. And I knew that. And so I didn't particularly want the government to control my life. So I thought, I got to take command of my own situation. So I literally went and made appointments with different schools across campus. And I explored, chemistry. I explored zoology. I explored dentistry. You name it, I went and explored it. And one of the schools that I went to was the School of Nursing. And I started to really think about, okay, what is that I find that kind of floats my boat? What is it that I'm drawn to? And I knew that I was drawn to really helping people. That was sort of my bent. And so I thought, nursing has much more of a fit than any of these other fields. And I had so many friends that were in zoology, and I thought, that isn't quite me. So I ended up enrolling in the School of Nursing, and I was the only male in the entire school for about the 4 years that I was in undergraduate program. I was a bit sobering to recognize that I was the only male. But I was very fortunate that my classmates never treated me as some kind of aberration or some odd dude. They really were very, very supportive to me. And I was very lucky, and I had a great bunch of classmates. And so I also recognized that I wanted to control where I was going. So I explored the Navy, and the Navy offered me a scholarship for 2 years to go to college And then I was commissioned and went into the Navy for 3 years of active duty. So my first duty station was Pensacola, Florida. I was there for 1 year, and then I went to St. Albans, New York for 2 years. And then left active duty to go back to graduate school, where I went to University of Washington in psychosocial nursing, which really captured my interest. And had you told me, one, that I would have gone on for a graduate degree, I probably would have laughed at you. And two, that I was interested in psych. And it really ended up being the right decision, because I have been in that field ever since. And I've had the enjoyment of doing all the things that I ever wanted to do in my career. So I taught, which I thoroughly enjoyed, had a lot of fun in teaching. I did research, and much of my research was in depression. And then I did clinical work. And I never would have wanted to do all three of them only. I mean, what I should say is I didn't want to do one of them solely. I enjoyed doing all three. And that's what really gave me the pleasure of the work that I did. So I've had a wonderful career over the years that I did research, teaching, and clinical work.
It certainly sounds like a wonderful career, a lot of really great experiences. In a lot of ways, you were able to touch people's lives in very different but equally meaningful ways. And so I know that you have dedicated a good portion of your career to investigating stress, coping, and depression, specifically within members of the military. And I have a feeling what kind of the inspiration there was, but will you elaborate a little bit on how you decided that this was going to be one of the key focuses to your life's work?
Mm-hmm. Well, sort of how I got involved in the research it started out with Navy recruits, and this was at Great Lakes Naval Recruit Training Center, which is in North Chicago. And how I got involved in that is that after I had left active duty, which was before I went to graduate school, and then I had forgotten, because when you were commissioned as an officer in the Navy, you were commissioned then for 6 years. So after I left active duty, I went to graduate school. And so I was actually in my doctoral program that I got a letter from the Navy, and they said, you need to make a decision. Are you going to retire reserves, which I wouldn't have qualified for? Are you going to go active reserves? Or are you going to resign your commission? So I decided that I would actually go back to the reserves, and I did. And so about 4 months later, the Navy sent me to the Philippines. And oh my goodness, what an experience. I was on a helicopter assault ship. That was all the salt that I had as a Navy man was my experience on that 3 weeks that I was on that ship. But that was it. But in any event, I really enjoyed the time that I was in the reserves, much more so than when I was active duty. But the Navy would utilize me because of my background, and I would go to a naval hospital and do a project for them. It was really in my area of expertise. And they would win, I would win. It was a win-win situation. So when I do my 2 weeks of active duty, so to speak, that's what I do. Well, I had gone to Great Lakes to sort of get to your question, is that one of the psychiatrists that was at the hospital, we got into a conversation, and I said, well, if you were looking at what is the most predominant diagnosis that you deal with at the Naval Recruit Command, what would you say it is? And he said it was depression. And I said, oh my goodness, guess what? I'm doing work in depression. Why don't we consider submitting a grant? We did. We got funded. We got funded 5 times for over 15 plus years that we got money from the Department of Defense to do research in depression. And so that's kind of how it started with, my being in the Navy and in the reserves, made that connection that otherwise wouldn't have been possible. And so that's how I really got involved and because of my area of interest in research was in depression, it was a perfect fit, and it just worked out extremely well. So we had studies going on up to the point of when I retired from teaching in the School of Nursing.
Wow, that is really cool. Very serendipitous that your studies aligned with what the highest need there was. So I'm curious, you have worked in mental health for decades now, and I just would like to know how your perspective and how society's perspective on mental health has changed from when you were growing up to your early career to where we are now. What are some changes that you've observed?
I would answer that question, Leah, from the perspective that when I look back at my parents, they were of that generation that mental illness was not discussed. It was taboo. It was a stigma. I had an uncle that was mentally ill, and they never talked about it. It was like putting the skeleton in the closet and locking the key. It just was not something discussed. To watch that evolve, and there's still a stigma associated with mental illness, but I have seen how that's changed, and the stigma has gotten much better in terms of not stigmatizing people with mental illness. So I'm finding young people of today, people your age, are much more open to revealing that they may have suffered depression than back in my parents' era. So I've watched that evolution occur. Are we there yet? No. In large part because depression causes a person to feel weak. And that's what they perceive in themselves. They're not weak, but that's how they perceive themselves. So therefore, they think they should be able to just pull themselves out of it. And because they can't, because they're suffering depression, then they feel that they don't want to let people know. But I have watched that evolution of younger people being much, much more willing to reveal what they're struggling with and open for help, where, oh my goodness, my parents would have never asked for help. And yet, I mean, they were fine. They didn't have any mental illness, but on the same token,
Yeah.
I knew how they kind of viewed the world in terms of that stigma.
Yeah. Certainly, stigma around mental health is decreasing, but as you said, we're far from a perfect world, perfect solution. So, but thanks to people like yourself who've been working in this field for decades, we are starting to see this reduction in stigma, which is incredible. And even in your retirement, you have maintained a practice at the Depression Center in the Department of Psychiatry. And I'm just interested in learning, why has it been so important for you to continue this practice even now?
Well, what it was is that when I was in graduate school and after I graduated, I actually volunteered to treat patients at the Community Mental Health Center that was in Seattle. And it was just north of Seattle is where I actually did see patients. So I carried a very small caseload. And I found that to be just so rewarding because I had a way of working with people in a way that I found that just really tapped and helped them to deal with whatever they were struggling with, whether it be depression or anxiety or other types of mental illness. And there's where I gained a reward. But as I mentioned before, I wouldn't want to do just clinical work only. So it was really that combination of teaching, research, and clinical work that really just made my career whole in that sense. So when I came to University of Michigan as the chair of psych, I wasn't seeing patients while I was in that administrative role. But when I got out of that, I ended up going back to carrying a small caseload of patients I treated. And it evolved into the Depression Center, what became the Depression Center. And then after I retired from teaching, I decided, I get such reward from working with the people I do, and I've had such good luck with people that I've treated, that I think I'll kind of continue doing it. So I only carried a small caseload that I'd only see patients on Friday. And then when COVID hit, I was seeing my patients via Zoom. And so it was all remotely. I was really worried, was that going to work? And so when I first started using it, I asked every one of my patients, do you feel like this has worked for you? You and I seeing each other like you and I are seeing each other right now. And I found that, by golly, they said, this is like me sitting in the room. And I realized that it was far better that we were doing this via Zoom than I would be sitting in the office with a mask on, having to sit 6 feet away from each other. It just was not conducive to therapy. And so by my being able to do therapy and medications, I did medication management with all my patients. So I had prescriptive authority. So I did it all. And I really was very rewarded. And my patients did it exceptionally well. I mean, it was just amazing of how well they would do. And I think in large part, it was the way that I approached my patients and the way that I worked with them that made all that difference. So I continued doing that. Probably should correct one thing that you said. I just stopped seeing patients at the end of December of 2022. And so I'm not carrying a caseload now, but I did that up to December. And so I just stopped doing that. And so I did that for quite a few years, even post-retirement, and decided, I think it's time for me to hang up my shingle. And I do miss my patients. I don't miss the paperwork and all the bureaucratic regulations that go on in healthcare right now. It's just so out of control. It's not even funny. And so I feel for the young people that are moving into the healthcare industry, because the paperwork is overwhelming. And it's not something that I enjoy. It's working with the patients that I really got the greatest reward from.
Oh, it certainly sounds like it. So based off of your years of clinical experience and working with patients, working with families, what are 2 pieces of advice that you would give to a family member supporting a loved one experiencing depression?
I did that a number of times, talking with families, because whenever I would see a new patient, and if their family was out there in the waiting room, I always offered the patient to talk with the family. And I would say almost in every case, the patient said, yes, I would appreciate it if you talked with them. So they would come in, and I would really educate them about depression as an illness, not a weakness. Because, see, they would often think that this person should just be able to pull themselves up by the bootstraps, get over it. I had one patient that told me that her husband said to her, well, just throw a little bit of water in your face and get over it. And it's like, no, you don't throw a little water in your face and get over it. This is an illness, not a weakness. And so that was one thing. And then I would also help them, both the patient and the family, to recognize that first, what the patient needed from them is their support. But secondly, that the patient needed to understand that it is not easy to live with someone who is so depressed and is so remorse and just so miserable that that's hard to be around, and how they themselves can help the family deal with them and the family deal with the patient. And it was amazing of how helpful that was, because I would literally show them a picture of the brain, explain to them how depression is caused, what causes it, what are the theories that are behind it, and what medication does and how medication works in the brain. And they would find that immensely, immensely helpful. And so that was something that I did almost with every single patient I treated, and dealing with the family. And so I think it's so important that family recognize that it's hard to be with someone who's really suffering depression. But secondly, how important it is for them to support that person as they get better and encouraging them to get better. And that's what they did. And it was amazing of how well that worked.
That's wonderful. Well, throughout your career, you have worked with a variety of different patients in different stages of life. And here at Carriaya, we work a lot with older adults. So I would love if you had any advice specifically for older adults who might be experiencing depression. What are some common barriers to accessing mental health care that older adults might be experiencing?
There can be really a whole host of factors that can affect a person that's older with depression. Very often, when I've seen older individuals with depression, that they have been suffering a lifetime of depression. And, with depression, time, people can get better, but there's still that level of depression that still exists. One of the problems of going untreated is that what happens with older individuals is that the depression symptoms get worse over time. Secondly, the interval between the depressive episodes become shorter, and the degree of depression becomes even greater in terms of depression in older individuals, to the point where they may be just chronically depressed. So then what happens is they become treatment-resistant depression. And that becomes very difficult then for a person then like myself to treat that individual for their depression. Now, one of the things that I often did with people that were, well, all my patients, and I actually made this a standard of practice that I did with the patients that I treated, was I used a genetic test that literally told you how they metabolized a psychiatric medication. So an antidepressant, an anti-anxiety medication, etc. So I would use that genetic test to see what meds, and the genetic test would put it in a green zone, a yellow zone, and a red zone. The green zone were the ones that the patient would likely have less side effects. And the yellow zone would be sort of in the middle. They might have side effects. And the red zone were the ones that they were more likely to have more greater side effects. So it was really helpful for me to see which medication that they would better respond to. So that would help me to narrow in, because before that, it was literally shooting from your hip. It was like, okay, I think this medication is going to work for this patient, but how do I know? And that genetic test really helped me to determine what medication to put them on. And that would make a huge difference. And so I think the bottom line to older individuals is don't wait. Get treated. You're suffering an illness, not a weakness. And the sooner you're treated, the better your life will be. And so that's one thing that I would reinforce with all of my patients that were older, of how important it was to be treated. And most often, these are individuals that then needed to stay on the medication for their lifetime. It would be no different than if you had diabetes. You wouldn't have someone that was diabetic and they were on insulin and you say to them, well, you can stop taking that insulin. No, it is something that they need because of the illness that they have. It's no different with depression. It's a physiological illness, no different than any other physiological illness. And that would be something that I reinforce to every patient I ever treated. And I would draw pictures for them. I would show them the brain, etc. And by the time I was done, they would truly understand it is an illness, not a weakness.
Absolutely. To finish us off, Dr. Reg, will you share one piece of advice for the pre-health students out there who are at the very beginning of their clinical healthcare careers?
I certainly can. And the biggest advice I'd give them is never say never. That's what I did. When I was an undergraduate, I said, well, no one else in my family has an undergraduate degree. So when I'm done with that, I'm done. Well, you can see I ate those words. And I think even when I thought about what area of healthcare that I would work in, I thought for sure I would work in intensive care. In fact, I did. And that was not my calling. My calling was really mental health. And that was what I really determined was what really got me excited. It was what gave me reward. It is what I found that I was really good at. And so if any advice I could give to a student that's beginning in this whole healthcare field is never say never. And two, open yourself up to a whole host of experiences. Take advantage of every learning opportunity you've got and see what surfaces as what turns you on and what gets you excited. And you get up every morning and say, ooh, I want to go do this some more. Then you found yourself. And that's what I did. And I reaped the benefits of that over my career.
Excellent advice. Thank you so much, Dr. Reg, for your time, for your voice, for sharing your insight and expertise. We really appreciate it. And that's a wrap for this episode of Future of Caregiving, brought to you by Cariaya. We hope you've enjoyed this exploration into the world of caregiving and you learned something new and valuable. If you want to stay up to date on all things caregiving, don't forget to subscribe, rate, and review. Tune in every week as we release new episodes featuring exciting guests and powerful stories.